There's just going to be a 5 or 10 minute presentation, and then we're going to break for lunch. David Kazarian is an IV company owner. He has been very generous to help with donations in this event, and apparently he's been very generous in helping patients who don't get insurance coverage and can't afford treatment.
You know, it's interesting. They asked me, what would you like to speak about? And I thought, well, saving folks money who don't have insurance. And so I don't have much to say. I've only got 5 or 10 minutes, but that's okay because there's not much we can do. Go to the next slide, please. I want to tell you a little bit quickly about myself. I've been a pharmacist for more years than some of you are old in this room. I've been a consultant pharmacist since 1974, walking into nursing homes and doing a lot of different things. And usually, in my consulting activities, what I've found with geriatrics is physicians will order drugs to treat symptoms of something that's caused by another drug. So I'd find myself suggesting drugs be stopped until I learned about Lyme disease. And a nurse came to me and said she wanted to know if I could find a physician that would order Rocephin for one of her patients because this patient had Lyme disease. Well, I quickly studied Lyme disease, and I said, oh, wait a minute now. I'm not certain this patient needs it. I went to a physician friend of mine, and he said, David, because you're asking me, I'll order it. And it got ordered for a couple of weeks, and I started saying, you know, maybe we ought to stop. And then I was forced to come to a Lyme support group meeting in Bristol. And I listened to patients talk about their conditions and what they had gone through, and I changed my opinion of folks who had Lyme. Next slide, please. As I said, in my practice, I've done a lot of things. I've been consultant to the insurance industry. As a matter of fact, one time I was asked to consult on a patient who got medications for Lyme, and I gave them the right answer. At any rate, I've been expert witness for attorneys, and I've done many things, and I've lectured at the University of Florida and the University of Connecticut. And I was humbled at the University of Connecticut when I suggested that the students there looked awful. They were awful. They dressed awful. They didn't look like professionals. And I said to those students, to the class, that they really should dress like a professional. And I was humbled when I heard that some students actually went out, next slide please, and got haircuts to listen to my lecture. But I'll try to keep you awake. Next slide, please. At any rate, my interest was in pharmacy and psychology. And why psychology? I share the interest with Dr. Raxlin because I was curious to learn how a little tick could inflict a psychosomatic disease on so many people. How could that tick bite make these people crazy? That's what the insurance industry told me. They said these people really don't need antibiotics. That tick bite gives them a craving for IV antibiotics, but they don't really need it. At any rate, next slide, please. So I'm going to give you, to see how well your minds are working, a little mental, I'm going to cleanse your mental palate right now. I'm going to ask you for, you know, as a pharmacist, sometimes we go, when we have a patient to check for dementia, we give them a mini mental exam, ask them some questions, and based upon their answers, we see what the level of dementia is. So I'm going to check this group. This test was given to healthcare insurance professionals. We'll see how you folks stack up against those. It was also given to preschoolers. Go ahead, next slide, please. How do you put a giraffe in a refrigerator? Does anybody have any idea? Did somebody say open the door? Open the door. Yeah, fine. Go ahead. Next slide, please. You have to click a couple times. Sure, open the door, put the refrigerator in, and close the door. This first question tests your ability to see if you make things overly complicated. Some people would say, bend the neck of the giraffe, take the legs off, do this and that. All right, the next question, the next part of this mini mental is, next slide please, and click it again. How do you put an elephant in the refrigerator? This is a tough one. Oh, you know what? We've got folks here that are just too good. What they said, go ahead. Those of you who said open the refrigerator, put the elephant in, and close the refrigerator, that's wrong. That's wrong because you have to take the giraffe out first. Go ahead. This tests your ability to think through the repercussions of your previous answer. Okay, next slide, please. Now, question number 3. The Lion King is hosting a big conference, and he invites all the animals. One animal didn't come. Which animal didn't come? Did you say elephant? You know, you guys are just, all right, next slide, please. Yeah, the elephant, you just put him in there. This tests your memory. All right, I'm going to give you the last question. Now, this is a tough one. Go ahead. You are at a river, and crocodiles use that river. You don't have a boat or a bridge. You must get across the river. How do you do it? Go take their elephant out of the refrigerator and ride it. No, that's not the right answer. The right answer is you jump in and swim across, because all the crocodiles are at that conference that the Lion King has. See, this tests. Go ahead. This tests whether you learn quickly. Next test. Now, this test was given to a bunch of 4-year-olds and healthcare professionals. 90% of the healthcare professionals didn't get one answer right, but many of the preschoolers did. So Anderson Consulting said this conclusively proves that healthcare professionals in the insurance industry don't have the minds of a 4-year-old. Next slide, please. Now, I'm going to show you something about how the mind works. I'd like you to read that. Go back one. Now, you all read that. How many people saw God Save the Queen? Raise your hands. Quite a few of you. You know, the mind is an amazing thing. When I started taking courses in psychology, I learned this. And I learned that with that thing that you just saw up there, I never had to pay for beer. Because I would sit there and bet people that didn't say God Save the Queen. People would look at it once, twice, 3 times. They would swear it said God Save the Queen. Go back. Now take a look at it again. Now what happens, and the reason that happens is our minds are amazing. We filter out unnecessary stuff. You're in this room, there are some people shuffling, there's things going on outside, there's a noise from that machine, but you're listening to me, or at least half of you are, and you hear what I say. You're filtering out the unnecessary stuff. Just like your insurer filters out the fact that you have Lyme. They think Lyme is something it's not necessary to treat. Next slide, please. And again. All right, now, paying for your own medication. Now, I'm going to tell you a little secret. Those of you who have health insurance, when you go to get your IVs and you go through your 2-week course of therapy and you're told you are cured, you can't get any more IV therapy. There's a disconnect in your insurance company. Only a few companies get it, because we've only had a few companies catch people. If you take your prescription card, now this is not IV therapy, take your prescription card, get that prescription for Rocephin or Clefrin or whatever the IV medication is, waltz down to your pharmacy, give them the prescription and the prescription card, there's about a 90% chance they'll give you that drug. Oh, it won't be ready for IV therapy, but that's probably the most expensive part of your therapy. Get that and then bring it to somebody who will mix it for you and you're ready to go. Next slide, please. There are other, if that doesn't work, drug companies have a compassionate program. Your physician usually will initiate it, but if you write the company and go to the company and talk to them about why you need the drug, how you've been on therapy, and how you just, this kind of therapy is, you know, even the wealthiest person in the world, when they're on IV therapy for a bunch of months, it hurts. And there are some people, I just can't imagine how those folks can afford to pay for their medications. We have one person who's up over $30,000 that I just heard recently, paying out of their own pocket for medication. So at any rate, if you go to the drug companies, sometimes the drug companies will help. Next slide, please. Now, cost-saving strategies, obviously, if you use an expensive way to deliver the medication, your costs will be higher. If you use an ambulatory pump, that's much more expensive sometimes than an elastomeric pump. If you use the elastomeric pump, that's sometimes more expensive than a syringe pump. And a syringe pump will be more expensive than a dial-a-flow, and a regular IV tubing will be the least expensive. All of which are there's certain inconveniences with all of those things, but you have to weigh the inconvenience versus the cost. Next slide, please. Simple little things like IV Lyme. If the CDC suggests changing an IV line every 72 hours. Now, some people say, well, I need a new IV line every day. Well, if you use proper procedure, now I say proper procedure, take the IV line when you're done, put a sterile end cap on it, put it in the refrigerator, and then next time you're ready to go, take it out of the refrigerator. We had one patient that I went to make sure that they were doing their procedure properly, and this person was doing everything exactly right except one thing. They didn't put the sterile end cap on the end of the IV tube. And by the grace of God, this person didn't get an infection. So you should absolutely use the proper procedure. Next slide, please. Tablets. Those of you who are prescribed tablets, you can cut them in half, because sometimes tablets, the half dose, the double dose, the single dose, they're all the same price. This is kind of persistent across the industry. For instance, a 50 cc bag of sodium chloride, 100 cc, and a liter cost almost the same thing. One's a little more expensive, but not 10 times as expensive. So if you have a tablet that you can cut. Now Kaiser, somebody sued Kaiser, the insurer out on the West Coast and here too. They sued them because Kaiser told them they had to cut their tablets in half. They went to court and they did not win because Kaiser demonstrated that nobody has ever suffered from cutting a tablet in half. Now, there are some places where you shouldn't cut a tablet in half, and that is if you have a capsule, obviously, next slide please. If you have a capsule, you can't cut it in half. If you have a drug where you've got to have very specific dosing, you can't cut it in half. If you have a gelatin capsule, don't even try. Next slide, please. Now, what about safety? I've had some patients tell me that, yes, they've gotten the medication, and they went out and bought the saline, and they mixed it themselves on their kitchen table. Well, can you do that and get away with it? Yes, you can. Are you looking for trouble? Absolutely. Remember, that's going right into your vein. Those bacteria that you might introduce are going right into your bloodstream. Now, why can we can tolerate those bacteria when we take oral tablets because we've got acid in our stomach that kind of cooks most bacteria, but not when it goes right into your vein. We and all IV companies mix drugs under a hood where there is a very fine filter that filters out most bacteria and viruses in an environment where we're mixing. Next slide, please. And we also sample every single dose that's mixed. Now, I always ask people, what's the most expensive drug on the market? And people say, well, let's see, it's Rocephin, or it's one of these biologically modified drugs. No, the most expensive drug that's on the market is the one that you don't use right. This is an article that talks about half of all patients take the wrong medications in the wrong doses at the wrong times or in the wrong way. Half understand the medication you've got. I was amazed. In 1974, we had a program for the frail elderly where we went out and we put all their drugs in calendar cards. And I asked those patients, tell me what this drug is for. About half of them didn't have any idea. I had one patient that was taking a painkiller 4 times a day because their doctor told them to take it 4 times a day. I asked, are you in any pain? They said, no. I said, why are you taking this? Because the doctor told me to take it 4 times a day. And she had been taking it for years. I had one patient that was taking, the reason we went out there, the daughter said, you know, my mother's sick, she's throwing up, she's seeing weird things. Will you go out and look at her medications? I went out, she was taking 2 different doses of the same tablet for her heart because the physician told her when she got the first tablet, you're going to take these for the rest of your life. She remembered that. When he gave her the lower dose because her levels were too high, she got the prescription for the lower dose, but she continued to take the other one because the physician said, take it for the rest of your life. So understand the drug that you're taking. If you don't know, if you're confused, ask the pharmacist. Ask lots of questions. Next slide, please. Understand your condition. You know, I went, there's a physician, Bela Bozic from Budapest. I met him, and I went to Budapest to visit Dr. Bozic. And when I went to Budapest, I asked to see the hospital where they practiced, and I was taken, this is years ago, through a primitive institution. Now, my thing is IV therapy. They had patients on TPN. They had 3 IV bottles hanging with tubing, strung up with gauze, from the ceiling, no IV pump, flowing down, and that's how they gave the patient the IVs. Well, I was being guided around by a physician who told me he just returned from Texas. He was lecturing for 2 years at Baylor. And I was shocked. I mean, here's a physician in Budapest in this hospital where they had primitive conditions. And he saw the look on my face, and he said, you're probably wondering why I was lecturing at Baylor. And I said, well, yes, doctor, why? And he said, you know what American physicians do? American physicians look at the machinery. They look at all the scopes and the dials and whatnot and diagnose the patient. Then they look at the patient. He said, here in Budapest, we don't have any of that machinery. We have to look at the patient. So I'm amused by insurance companies saying, you don't have Lyme, you've got a psychosomatic disorder. Next slide, please. You know, when I talk about sterility and mixing, the United States Pharmacopoeia has just come out with standards for companies like ours, and the standards say you've got to meet certain criteria. You can't just mix under a hood, you've got to have a room where the air is sterile. And then you have to have an ante-room where you prepare yourself before you go into there. And we've done this. We've been this way since we built our pharmacy, since we moved into our new pharmacy more than 10 years ago, 12 years ago. That's why I point all of this out, because when you think you can mix in your kitchen table, you can't. You can't. Our regulators are even making more stringent regulations for companies like ours. Next slide, please. When you have insurance and you go and you get a prescription, you should always, I've seen co-pays go up. I remember when co-pays were $2, and then they went up to $5, and then $10, and now I'm hearing co-pays like $25, $35, depending. Always ask, before you present the prescription, always ask, how much, before you present your insurance card, how much is this prescription? There are many times that your copay will be more than the cost of the entire prescription. And also, ask about generics. Now, generics used to be a bad word. A Ford is a generic Chevy. It's brand interchange. There are some generics. Generics can be a lot less expensive. You should look at those things. Look at your prescription, understand what you're getting and why. Next slide, please. Okay, that's all I've got to tell you, except one thing. You know, the Pope just died, and the Pope was standing there, and St. Peter said, come right in, Pope. But right behind him was a gentleman, And St. Peter said, what makes you think you'd be welcome in heaven? And he said, well, I've led a clean life. And St. Peter said, well, what kind of job did you have while you were on earth? He said, well, quite frankly, St. Peter, I didn't work. I've had Lyme most of my adult life, and I was unable to work. And St. Peter said, oh, you've already been to hell. You can come in. Thank you very much.
Thank you very much.
David? Thank you. You're a friend of the Lyme community. Thank you very much. Okay, we're going to break for lunch. If we can eat real quick without getting indigestion, because we got a lot more to pack in. Dr. Horowitz is going to do his song after lunch, too, Ode to the Deer Tick. You'll love it. Sandwiches are in the back, tuna fish, vegetable, ham, turkey, and chips are underneath the table.
Hi, it's nice to be here today. I thought you Lyme patients actually have suffered enough. I'm not sure why they asked me to sing for you today. It's not very compassionate of the people who put this together. This song was a song called Ballad of the Deer Tick, otherwise known as Where Nobody Goes. You'll understand the meaning after I sing it. I had written it for one of the LDF conferences years ago, so I hope you enjoy it. People have told me actually I should publish this and give up my day job, so you let me know afterwards what you think. Clyde came to my office one bright sunny day, said, Doc, I'm in an awful bad way. See 19 docs and I'm almost dead. All they can tell me is it's in my head. Doctor, please help me, please. I said, Clyde, can you tell me what you did in life that caused you all this terrible strife? Said, Doc, I was with my beautiful wife in the woods one day enjoying life. We laid down on the ground and we fooled around. Before you knew it, I was illness bound. From that day onward, I've been going downhill. Can you give me a lotion or a potion or a magic pill? Doctor, please help me, please. Gonna pick off a tick real quick before the devil gets within. Crime for the Lyme to steal my mind. I sure could use it for a little more time. Hurts over here, it hurts over there, it hurts in places everywhere. Hurts in my fingers and it hurts in my toes. It hurts in places where nobody goes. I said, Clyde, this is your lucky day. I know why you're feeling in such a bad way. That night in the shower, did you check to see if there was anything attached to the back of your knee? Or any place else, or any place else? You know what I mean? Did you notice a mite or a bite or a tick or a ring or any such unusual thing? Did you shake or quake, get hot or cold before your illness really took hold? Clyde looked at me with a tear in his eye and he let out one enormous sigh. He said, Doc, I remember some unusual rash on my nose and my toes and when nobody goes. Gonna pick off a tick real quick before the devil gets within. Be a crime for the Lyme to steal my mind. I sure could use it for a little more time. Hurts over here, it hurts over there, it hurts in places everywhere. Hurts in my fingers and it hurts in my toes. It hurts in places where nobody goes. I said, Clyde, this is not chronic fatigue, fibromyalgia, systemic lupus, trigeminal neuralgia, halitosis, multiple sclerosis, or any hocus pocus diagnosis. It's about time you got tested for Lyme. It'll be wiser to check your ELISA. It'll be easier to treat your babesia once we show your HMO the proof they need, the proof they need. Just pray you'll be lucky indeed. Pick off a tick real quick before the devil gets within. Crime for the Lyme to steal my mind. I sure could use it for a little more time. hurts over here, it hurts over there, it hurts in places everywhere. Hurts in my fingers and it hurts in my toes. It hurts in places where nobody goes. The moral of the story is don't fool around with Lyme disease, 'cause here's what we found. The mice aren't nice, steer clear of the deer. The ticks are really a pain in the rear. With Lyme disease, one surely knows it goes in places where nobody goes. Pick off a tick real quick before the devil gets within. Crying for the Lyme to steal my mind, I sure could use it for a little more time. Hurts over here, it hurts over there, it hurts in places everywhere. Hurts in my fingers and it hurts in my toes. It hurts in places where nobody goes. I really wanted to be a singer-songwriter, but my mother told me to become a doctor. So, smart mother, yes. It's a Jewish mother. You know how they are. My son the doctor, my son the lawyer. There wasn't many choices here. I mean, thank you for inviting me here today. It's a pleasure to be with you. I've spoken before probably many of you. When they told me that Leslie wanted me to come here and speak today, you know, I thought about this conference and what I could present to you today. So this is going to be an overview. Many of you have probably seen this before, but what I'm going to try and do is to give you an overview of what we do in our medical office and to try and synthesize a lot of the information that we have on Lyme disease and the co-infections and show you exactly what we do in my office. And in honor of Dr. Fine today, I would like to call her Dr. Very Fine, Dr. Extremely Fine, Dr. Unbelievably Fine. So if she hasn't had that nickname before, I'd like to start that nickname today for her. This is the universe of Lyme disease that we look at in our office. You'll notice in the middle, you'll find Borrelia, Ehrlichia, Babesia, Bartonella, Mycoplasma, Chlamydia, viruses. These are some of the bugs that we think about looking for when we see Lyme patients. And you'll see on the right side some of the drugs we use. We think of Lyme as having cell wall forms, having atypical cystic forms. It goes intracellular, where we might use macrolides. And you'll see at the bottom, now we think in terms also of neurotoxins. Possibly thinking now about IV glutathione, which is something I've talked a little bit about the past conferences, and I'll share with you today. Many of these patients also have immune dysfunction. You can see that at the top. They're ANA positive, rheumatoid factor positive, HLA positive. So what we're looking at with these patients, it's not just a question of having Lyme disease with chronic borreliosis syndrome. Really what we're looking at least is the way I see the universe of this, is we're looking at Lyme, we're looking at all of these co-infections, we're looking at neurotoxins, we're looking at autoimmunity and immune dysfunction, and sometimes we're looking also at environmental toxins. You can see at the bottom, some of these people may have environmental illness. We've been testing our patients, many of them who test now positive for mercury and lead and arsenic and cadmium and many of these heavy metals. So I'll talk a little bit about that today. We know, I'll first give you just the quick Lyme 101 primer. We all know it's a multisystemic bacterial infection spread by the bite of an infected tick. And the infection, Borrelia, what many people don't know is that there's 100 US strains and 300 worldwide strains. And this, of course, could explain why we see this diversity of syndromes in so many people. There's Borrelia lone stari, Borrelia Miyamoto. This is related to the relapsing fever bug in Japan. About 10 to 20% of the Borrelia in the Northeast are genetically related to this bug, and that may be why they don't test positive by ELISAs and Western blots. And of course, in Europe, we have Guerini Evzeli. You've seen the helico-shaped organism, Helicobacter. We talked about it. One of those organisms now that causes gastritis and stomach cancer. I got interested years ago when I saw this because one of the first studies that I had presented at the LDF conference in '99 was the use of Flagyl for Lyme disease. And Dr. Brorson then had published 6 months later on the use of Flagyl hitting the cystic forms of Lyme. And that was actually quite interesting. The transmission, we know that ticks acquire the bacterium by feeding on an infected animal, and will pass it on. And the 4 life stages many of you have seen. What you may not know is we don't usually talk about the larvae necessarily transmitting Lyme, but it could actually be one of the reasons why you never see a tick bite. Possibly maybe 1% of larvae at this point may be carrying Borrelia. So if you get thousands of larvae on you while you're walking through the woods, they're so small you might not see them, and even if you were lucky enough to pick up a nymph. So that may be one of the reasons we don't find it. And of course, you know what the tick looks like, the female adult tick. Of course, the larger one, which is red with the black scutum, is of course the one we're looking for that transmits Lyme. And the larger ticks, of course, are the engorged ticks. Many doctors feel that unless it's engorged, it can transmit Lyme, but of course, there are many theories that even after several hours, it's possible, especially if you don't remove it properly. So of course, never squeeze it, just lift it straight up. The Lone Star tick is something I hadn't seen in New York until a couple of years ago. That's the one with that little watermelon seed shaped on its back. I have seen a couple in New York. I was surprised years ago. Gloria Wenck actually came to my office. She was one of the first women of Lyme disease in Dutchess County and confirmed, in fact, that that's what we had found in our office. And the thing about Lyme and co-infections is, of course, it presents as either an acute or a chronic illness. And the acute Lyme disease, of course, it's a little bit tricky because you might just think you had a flu-like type viral illness in the middle of the summertime. But of course, that's the key. We may not get many viral illnesses in the summer. So of course, if you present with sore throats and aches and pains, you must think Lyme. Any person, of course, who gets Bell's palsy has to be strongly considered to have Lyme disease. And the thing about the rash, of course, which is most important, is only 50% or less of the patients get an EM rash. And of those rashes, only 50% or less look like classical bullseyes. So, of course, this is a classical Bell's palsy and a classical EM rash. But unfortunately, most of the rashes we look at might look more like that. It's a little bit darker in the center, and it tends to spread outward. Or, again, fairly typical with these circular lesions. That one maybe not so typical that you might see in a doctor's office. And these are quite common also, these flat rashes that this one's triangular in shape, that a doctor might diagnose as being eczema or contact dermatitis. This is one that's going around the umbilicus, a little bit more difficult to see. And of course, in the scalp, we have to look all over because it goes in places where nobody goes. An acute disseminated Lyme, by definition, if you have multiple rashes all over your body, you have acute disseminated Lyme. This means automatically it has gone into your central nervous system. You would never expect someone with several EM rashes to be treated with just 30 days of antibiotics. There's no way in the world you will ever cure someone with it. So what are those symptoms of disseminated Lyme? Well, multiple rashes per bite, lymphocytomas, acrodermatitis chronica atropicans, probably seen more in Europe than here in the United States. Neurologic headaches, meningitis. Now, you know the Lyme meningitis, it's not the same kind of meningitis you might get with meningococcal meningitis or pneumococcal. This is kind of subtle with those stiff necks and headaches. But the point is anyone who gets bit that has a stiff neck or a headache, of course you know that you've got dissemination into the central nervous system. Cardiovascular, very common that Lyme patients complain of those irregular heartbeats and palpitations. Many of them go for Holter monitors, echocardiograms, and stress tests for that chest pain that you all get, which a lot of times is costochondritis. Of course, with adequate risk factors, you should get a stress test, but most of the time it is costochondritis. Ophthalmologically, we see inflammation in different parts of the eye, and probably the people who have the worst eye problems are the ones who are co-infected with Bartonella at the same point in time, who might not respond, or have a uveitis where it's very difficult to get those antibiotics to penetrate deep into those layers in the eye. Musculoskeletal, the hallmark, I think all of you know at this point, if it's migratory aches and pains which move around your body, it is the only disease which does that. This does not happen with rheumatoid arthritis or lupus or fibromyalgia, where one day it hurts in one place and it moves someplace else. It's of course possible to still get it in just one joint without movement, but the classical presentation, of course, is it moves around the body. This is a classic third-degree heart block. I've only seen a couple of cases in my 20-year career with over 8,000 Lyme patients, and all of them resolved adequately with antibiotics. They did not need pacemakers. A case of optic neuritis. There was a nurse manager in my hospital who lost her vision in both eyes from Lyme disease, and unfortunately the HMO would not approve ongoing treatment with bicillin, and unfortunately she did lose her vision and she's no longer able to work. Acrodermatitis chronica atropicans, this is the rash that we very rarely will see in the US. Occasionally you may see it. And the clinical pearl about disseminated Lyme, really the most important thing to know about an EM rash is that if you have a stiff neck, if you have a headache, or if you have paresthesias, those tingling or numbness sensations in your extremities, that means it's spread to your central nervous system or your peripheral nervous system. You would not expect that those symptoms, you're going to get rid of Lyme with 30 days of antibiotics. So most doctors then would treat until patients are at least 2 months symptom-free. So this is where we really do have a chance to try and eradicate the organisms completely from the body. As far as co-infections, in my practice, I really think of chronic Lyme disease at this point as being seen in light of all of these different co-infections. Ehrlichiosis, human monocytic, human granulocytic, now also known as anaplasmosis. Babesia microti, one of the most important co-infections you will ever see. Dr. Krauss had published in JAMA in 1996 that those of you who get Lyme and Babesia, you're 4 times sicker, you have a much more severe illness, and a much longer duration of the illness. And that is exactly what we see in all patients. So since it's malaria-like, if you present to a doctor's office with fevers, sweats, day sweats, night sweats, or chills, you have to strongly think Babesia microti. And unfortunately, there are many different forms of Babesia. There's Babesia WA1, which is in California, and there are probably other forms of Babesia that we can't test for by immunofluorescent antibody or by the FISH assay. And that probably would explain with these pyroplasms why you don't get positive Babesia testing, because there are so many different pyroplasms that are out there. We are finding many patients who test positive for Bartonella, probably at least 50 to 60%. In Dr. Fallon's study, the chronic Lyme encephalopathy study, he was finding up to 60% of his patients were positive for Bartonella henselae, the organism of cat scratch disease. And when Brian had presented at the last conference, he had said that although some of these patients clearly improved with Rocephin, the ones that didn't, when they were treated with, for example, doxy and rifampin, a Bartonella regimen, they got better. So it wasn't a question that their chronic Lyme was just due to Lyme. It was these co-infections that were playing a role. The symptoms of these diseases overlap. This is why it's very important to look for all of these co-infections and to treat all of these co-infections, because my experience is once these co-infections are adequately treated, patients will improve. The problem is that even treating Lyme or Babesia or Bartonella or Mycoplasma long term, we have definitely seen evidence that these organisms persist in the blood by PCR or in the urine. So if we look briefly at Lyme disease as far as symptoms, testing, and treatment, the EM rash, of course, is definitive evidence. You do not need a positive blood test, and even the NIH was willing to use that criteria. It's these flu-like symptoms, it's migratory aches and pains, you're tired, you have headaches. The tingling and numbness is classic. Unless you had carpal tunnel syndrome, where you would expect to have that tingling and numbness every day, there's no other disease where that tingling and numbness moves around your body, right? And especially you might have it in your face, and you look on the MRI, and there are those unidentified bright objects that are showing up that many of the Lyme patients have. They might be photosensitive. Hearing also can be impaired or very sensitive to sound. And of course, the cognitive difficulties, which is why for American, for the world, this is so difficult, because literally what's happening is, in my area, we have a lot of IBMers. These people go to their computers and they can't remember their keystrokes because the Lyme has gotten up into their brains. So this is a very serious health problem, of course, that we all know about. The testing of the ELISA, this 2-step protocol that the doctors usually are talked about, of course, the problem with the ELISA is you only want to test to be at least 95% sensitive on a confidence interval to use it as a screening test. The ELISA, and you can read this in the package inserts, is usually 50% or less. So the C6 Lyme ELISA peptide is clearly a better test. It's probably 3 to 4 times better, and I think it's worth looking at. But I still like the Western blot. And I especially like the bands on the Western blot, which most of you know, there are 5 bands, and we call them Lyme bingo, because if you have any one of those 5 bands, bingo, you have Lyme disease. And what are those bands? The 23, the OSP-C, the 31, the OSP-A, which you would only get unless you had the Lymerix vaccine, the 34, the OSP-B, the 39, and the 93. So those bands are pathognomonic of Lyme. And many of the Lyme literate doctors, of course, have shown this in studies, and it was published by Ma et al. In the early 1990s looking at the banding on the Western blot. In our treatment, we usually try and use treatment courses which hits the cell wall forms. These non-cell wall forms are cystic forms. Plaquenil, Flagyl, tinidazole can be used for that. And of course, it goes inside the cells. So we might use macrolides, like Zithromax or Biaxin. The ketolides, like Ketec, may seem to have some usefulness because it's bactericidal, and tetracyclines. But if we want to understand the role of where the lab testing fits in, the first and foremost, which all physicians, of course, need to understand is, and even the FDA have said this, it's a clinical diagnosis, right? It is not a diagnosis that's made by a blood test. The problem is you have to be an astute clinician to understand the gestalt of the symptoms of what is Lyme disease, where the symptoms come and go and migrate with the paresthesias and the memory problems. Now, just take memory and concentration problems. If you were a board-certified internist and you went into my office and you said, I'm 36 years old and my brain doesn't work, I can't remember things, I have word-finding problems, I'm reversing letters and numbers, what would be the differential diagnosis of what you'd think of? Well, you might think hypothyroidism and check thyroids. You might check for B12 deficiency and even check for occult B12 deficiency with methylmalonic acid and homocysteine levels. You might check for heavy metals with mercury and lead, right? And you would check for Lyme disease. There really are not a whole bunch of things in a young person that are going to cause this level of severity of memory and concentration problems, especially if you've done a CT or an MRI and you're not seeing anything significant, such as a brain tumor. So the differential diagnosis just with this one particular problem of memory concentration is not that extensive. And it's the same thing if you really start to break down. Of course, fatigue is very difficult because there's 1,000 things that cause fatigue. Same thing with headaches. But memory and concentration or paresthesias with tingling, it's carpal tunnel, you do an EMG, or maybe you had arsenic toxicity or lead toxicity, which gets into the nerves. But again, there's not a million things apart from vitamin deficiencies and heavy metals that often will cause this, unless, of course, you're a diabetic with polyneuropathy, but not a lot of differential. So it's important for doctors to know the differential diagnosis of those individual symptoms, and that's one of the ways you can rule it out when you see a patient. The EM rash, we said, is definitive evidence. Patients are also seronegative if they test early or take antibiotics. We talked about the two-tiered protocol. It's really inadequate because the ELISA is not a very sensitive test. And there are those bands we talked about on the Western blot that we look for. And the reason we tend to use IGeneX and not some of the local labs is because the local labs use the B31 strain. They've never standardized in the United States, and that's only one strain. Whereas IGeneX takes multiple strains, and that's why they get different banding on the Western blots when the local labs may be negative. We find PCR to be certainly an important tool for Lyme disease. We use MDL labs and other labs to check for it. Not very easy always to find it, but when it comes back positive, as it often does in our practice for Bartonella and mycoplasma, it's very useful because that would tell me as a clinician I may have to use 2 intracellular drugs at once because we've been finding that one intracellular drug alone may be inadequate for these bugs that hide out intracellularly. 10 to 20% of the Borrelia in the Northeast, as we said, are not Borrelia burgdorferi, but are genetically related to Borrelia miyamoto, the organism that causes relapsing fever in Japan. Well, if you think about 20% of the ticks carrying these atypical Borrelia, that would mean if you took 10,000 patients who got Lyme-like syndromes, at least 2,000 of them would have these atypical Borrelias, could still present with a Lyme-like illness, but not necessarily be quote-unquote Borrelia burgdorferi. And this probably also explains why doctors are so confused when the tests are negative. You need to understand the number of Borrelia and the number of strains of these organisms that are in the environment. Other tick-borne diseases such as Babesia and Bartonella, very difficult to find. The IFAs, not easy always to find them. In Bartonella, I'd say only 50% of the patients test positive. We need to use PCRs repeatedly to try and find it. But many of these patients, when they test positive finally and are treated, they do very well. And finally, any positive titer for any tick-borne disease, it would make you think it's at least possible that other tick-borne disease may have gotten into your body. So this is where if someone, for example, was in a tick-endemic area and just took amoxicillin and didn't get better, or Ceftin, you'd say, well, okay, maybe they got Ehrlichia, maybe they got Babesia. These are not covered by amoxicillin. So chronic Lyme borreliosis syndrome. What are we talking about really with chronic Lyme disease? Well, from my experience with Lyme disease, there's certainly a lot of peer-reviewed literature that has been shown that Lyme persists in the body. So we know that Borrelia can persist despite extensive courses of antibiotics. So that's one of the reasons, of course, many of you in the audience stay sick. A single tick bite also transmits multiple organisms. In my practice, I definitely see patients get better when these co-infections are found and they're treated, such as ehrlichiosis, babesiosis, Bartonella, mycoplasma, chlamydia. Many of the co-infections are intracellular. We know that intracellular bugs are extremely difficult to cure. And that's part of the reason we like using long-term intracellular antibiotics. And in our practice, we've started to use 2 drugs sometimes to try and treat these difficult intracellular infections. What about immune dysfunction? Clearly, Alan Steer is not completely wrong. It's just he doesn't have the whole picture, as many of the doctors do. There is an autoimmune problem with Lyme patients. There clearly is. There is tremendous immune dysfunction, especially if you're HLA-DR2 or DR4 positive, or you're B27, or have any of these markers. So Plaquenil, of course, is used in many of these patients to help modulate the immune system. So, absolutely. Okay. Excuse me just one second. A more important speaker than myself has come. In fact, much more important. Please welcome Attorney General Richard Blumenthal.
I want to say how delighted and proud I am to be with you today, as I've been with many of you on past occasions. And I think back to all the fights, all the years that we've been together in this battle against Lyme disease. There was a time when Lyme disease was the most prevalently illness denied coverage. More cases of Lyme were denied coverage than any other disease coverage by insurance companies. And people in this room and I and others have fought over the years since 1998, when we had the first hearing again in 2002, to make sure that there is greater fairness and accuracy in this test. And we still have a ways to go. We still have a battle ahead of us, but I'm so proud to be fighting it with you, because you folks are doing a service not just for yourselves and your families, but for literally thousands, hundreds of thousands, millions of people across the country who suffer from this insidious dread disease. And I want to thank two groups of people: the families of victims of Lyme disease, who demonstrate just incredible courage and relentless determination. I have met with many of you, and your stories are just endlessly inspiring and moving for me. So I thank you for your constant bravery in the face of so much adversity. And I want to thank the docs, the doctors who stand up, speak out, fight with you against this disease, against many in their own profession. But they too demonstrate tremendous courage. And I have the great honor of joining with you in honoring one of those doctors, and also one of the pioneers and the champions of this disease, in presenting some very special awards today to Dr. Jones and Polly Murray, two heroes in this movement.
Dr. Mara will take this one.
This is to Charles Ray Jones, who deserves a standing ovation. Now, I want to apologize that he could not be here today, but we're going to tell him about this standing ovation. And accepting on his behalf will be Dr. Mara. Sorry.
Here we go. Which one? Is it this one or this one? Is this one? Well, I had the opportunity to talk to Dr. Jones last night because Randy had called me and asked me if I would accept this for him. And Dr. Jones said, well, what are you going to say? In his very sort of, just gentle, calm way, he said, well, why? Well, what are you going to say? And I thought to myself, what am I going to say? And I thought about, I've been working with him for 2 years, every week for 2 years, largely because in our practice down in Westport, we started to see all these very strange and insidious symptoms in children. And through a circuitous route, I happened to find my way to Dr. Jones, and lo and behold, it was exactly where I needed to be. And since that time, I've been working with him, and we've developed a nice friendship. And there's a couple of things that he says to every child that comes, and he sees the sickest of the sick. I mean, sick beyond belief. Sometimes I leave there with tears in my eyes that are so thick I can't drive home. And one of the things that he says to every child is, "How are you feeling?" And they say, "Fine." Meanwhile, they can't walk. Some of them can't see, they can't hear, they can't read, variations on those themes, but they say, "Fine." And he says to them, very gently, he says, "But would you like to feel better?" And they say, "Oh, yes." And then the next question that he asks them is, "Are you still a perfect child?" And for the last 2 years, I've thought, what a wonderful way to gently say to a child who's experiencing such great suffering that really no one has any idea about how the ramifications of their suffering. What a great way to capitalize on the gifts of every child, even though when he sees them, they're in the depths of their darkness. So for his sake, he's an extraordinary person. He has the warmest, kindest, gentlest heart of just about anybody I know. He's dedicated his life to children who have this insidious disease. And I know you as well as I wish him the very best. And I know he would have loved to have been here, but he's sitting in his office seeing 10 to 12 patients today.
Thank you.
Next, I would like to call to Polly Murray, who has been, as the plaque says, a pioneer in the fight against Lyme disease, and I'm very proud to present this award to you. Actually, Dr. Horowitz has very, very explicit and clear notes here, so I could go on with his presentation. But I do want to apologize again. I know from the notes that it was very interesting, and I know we all look forward to hearing the rest of his presentation. And thank you so much. Thank you very, very much for letting me share.
It's wonderful to have public servants who are compassionate, who understand exactly what people go through and listen. And that's what Dr. Raxton was talking about this morning, is listening. It's a very unusual trait in people, and this is one of the gifts that I think that Attorney General Blumenthal has, is compassionate listening. So continuing on, just as far as chronic Lyme goes, the last point on this slide that you see is neurotoxins, and it's been talked about before. Quinolinic acid was something that Dr. Halperin had published about in neurology in the early 1990s, and there's also was talked about at one of the LDF conference about a toxin called BB-Tox1. It might explain in some of the Lyme patients why, despite antibiotics, you still have brain fog and fatigue and joint pain. And what we found in my practice is using IV glutathione in some of these patients. Miraculously, the brain fog and the fatigue and some of these symptoms get better. So what we're planning on doing this year, towards the end of the year, is to do a double-blind placebo-controlled trial. A wellness pharmacy from Alabama is going to be funding it. We're working with the University of Cincinnati Medical School, who's going to be helping me to write up the paper. And we're actually going to do a study to determine whether this is just, in fact, a placebo effect, or whether there really is something going on with the use of glutathione. So as far as why is Lyme disease chronic, many of you have come here today, of course, with this diagnosis. And the testing, of course, we know is unreliable. The organisms can evade immune surveillance. And the scientific research has clearly shown that the labs at this point have not been standardized. There's problems with timing of antibody synthesis. false negatives if you test too early or give people antibiotics. You can't detect it because there's circulating immune complexes, which is one of the main reasons, probably many times, you can't get back a positive test. The biology of the organism, it's a very slow-growing organism. Antibiotics only work well when the organisms are replicating quickly. So that's why you have to stay on antibiotics for long periods of time, because even in culture, when they took an EM rash and put the Borrelia in culture, some of those Borrelia did not come out of culture for 10 months. They lied in dormancy until they started reproducing. So you know that normally for chronic Lyme disease, at least a year of antibiotics is going to be necessary for most people. And of course, there is a problem with a suppressed immune response. Not just a problem with Lyme. If you look up in the literature regarding Ehrlichia, Babesia, Bartonella, you'll find, in fact, they all can suppress the immune system. And no one has really done a study to figure out what happens when you get all these bugs in your body at once, as far as what happens to the immune system. So we know that there's lab variation. This was published by Bakken et al. In JAMA in 1992, that if a lab was asked to test, they couldn't even reproduce their own results in many of the cases. The IgM antibody, it takes 2 to 5 weeks, and then it may disappear. But the interesting thing about Lyme is, and many of you know this, the IgM antibody turns up positive later on in your disease. When Dr. Fallon was trying to do his chronic Lyme encephalopathy study and find IgGs, he was really finding a lot of IgMs. Very, very common in chronic Lyme. So usually IgM means early. In this particular disease, you find it in both early and late Lyme. So it varies a little bit with that. False negatives, if a doctor had treated you for a sore throat and thought that it was a bacterial infection, it could have wiped out your immune response. So you might have had Lyme and never gotten an immune response. The circulating immune complex is very important to understand this. Dr. Coyle from Stony Brook has published on it, and I would say probably one of the most important things about this is when you do your spinal tap, the reason the spinal taps are often negative for Lyme, and this was also published by Dr. Priyak-Mersic about negative spinal taps, is that you have circulating immune complexes in the spinal fluid. And this is what they were finding. And Dr. Liebner has sent to Stony Brook, to Dr. Coyle's lab, 200 spinal taps, and discovered that 25%, 50 out of those 200 who tested completely negative by all standards for Lyme, were positive on an immune complex dissociation assay. Unfortunately, Stony Brook does not do that test regularly, so we're missing a very good test for proving ongoing neurological Lyme disease. We also know that there are metalloproteinases that are also in the spinal fluid. This was shown by Dr. Klempner's study, also specific, so it kind of gives us a clue with that also. Biology of the organism, we talked about. Antibiotics are effective when it's reproducing. And they have plasmids. They have more genetic material than any other organism on the face of the planet. And that's part of the reason when you go to the conferences, you'll see that they can interchange genetic material. There are hypervariable regions on the outsides of these spirochetes, and they can change their structure so your immune system can't recognize it, like relapsing fever. And the Borrelia can actually exchange genetic material between them. So that's how it keeps evading the immune system in part also. We also know that they secrete blebs from their surface, and it's been shown that these blebs can cause a nonspecific stimulation of the immune system. This may be one of the reasons why you get those ANAs or rheumatoid factor positives, and I also believe that some of these co-infections may be responsible. We know with mycoplasma that it can cause polyclonal B-cell activation and also cause immune stimulation. So it's possible that there may be multiple factors causing this type of an immune or autoimmune picture in some of the patients. Borrelia can surround itself with the body's own lymphocytic proteins. This is kind of an unusual cloaking mechanism that Borrelia has. And Dr. Chow from New York Medical College showed at the LDF conference years ago that if you took a vat of Borrelia with T cells and you put it in long enough, it would suppress the immune system. There was problems with interleukin-2 production, which was also inhibited by the spirochetes. Dr. Dorwood from the NIH did a study where he used the electron microscope, and he showed for the first time with bacteria that there was B and T cell destruction. So this was also an area where Borrelia was killing off your lymphocytes. And what he showed is that normally when your lymphocyte tries to eat the Borrelia, you have these little things inside of your cells called lysosomes. They contain acids. You're supposed to kind of release it and destroy the organisms. Well, with Lyme, there was no lysosomal fusion. The organisms escaped the lymphocytes while killing them, and they surrounded themselves with your body's own proteins, lymphocytic proteins. So when the immune system tried to recognize it, what it saw were your lymphocytic proteins. It has this type of a cloaking device. And finally, we know that these organisms can sequester in places in the body where antibiotics do not penetrate well. This is the central nervous system, deep in the glial cells of the CNS. deep into the joints, the fibroblasts of the skin, the anterior chamber of the eye. And these are several studies. It's kind of difficult to see on here, but you can see Dr. Priyak-Mersic had published an infection early on chronic Lyme, Haupel persistence in ligaments, Dr. Coyle, seronegative chronic relapsing neuroborreliosis. This was a patient who had Lyme in the spinal fluid despite ongoing courses of Rocephin, where they could still culture it out. Dr. Liebner had found the same thing with culture-confirmed treatment failure of cefotaxime, of clafran, and minocycline. And Dr. Klempner, who had published the NIH study on Lyme, he had actually published in the early 1990s that if you took a vat of Rocephin and you took fibroblasts from the skin, which had Borrelia in it, the fibroblasts would protect the Lyme spirochete from the Rocephin. So after a week, you would take it out, and the spirochetes were still alive. So I don't know why it was so difficult to come to the conclusion that Rocephin didn't work in these patients, because it was able to hide in the body. And finally, the only animal model we have is Dr. Straubinger. He had published from Cornell in dogs, where he took 16 beagles, 12 of them he gave antibiotics, 4 he didn't, and then he did PCR studies, punch biopsies every 2 weeks on these dogs after he gave them the same standard 30 days of antibiotics that you or I might get, doxycycline, Zithromax, Rocephin. What did he find? Did it cure it? No. What it did is it lowered down the number of organisms almost 1,000-fold. Well, that makes sense. That's clinically what we see in our practices. You get better, but you don't completely resolve, and that's what was found in the animal model also. Dr. Fallon's study was in direct contradistinction to what was found by Dr. Klempner's study in the New England Journal of Medicine. This was a study of persistent Lyme encephalopathy, those of you who had brain fog with chronic Lyme disease, and he had to go through 3,700 patients to find 37 patients, 1%, met the criteria for IgG CDC positive Western blots. Now, these were people that had already been diagnosed with Lyme disease, but only 1% met the CDC criteria. So these subjects had evaluations. They had self-reported scores of functional status, anxiety, fatigue, MRIs, and PET scans. And he did a 10-week double-blind placebo-controlled trial. And what did he find? Well, the Lyme patients were as sick as patients with chronic congestive heart failure. Interestingly enough, this was found in Dr. Klempner's study also. Only 1 patient had fibromyalgia. So all of the Lyme patients who are told they have fibromyalgia, that's not what they found in the study. There were minor neurological involvements, but at week 12, it favored the drug regimen versus placebo. So this study that will soon be published found that long-term IV antibiotics, in fact, did help chronic Lyme patients. And it wasn't a placebo. And what was great about the study, he did PET scans of their brains. He looked at the metabolism of glucose in the brain to find out what did Rocephin do, and they saw changes in the brain structure on the PET scans when they took Rocephin. So this was a very, very interesting study. It was a great study. And as you see at the bottom, 60% were positive for Bartonella. And the ones who didn't respond to Rocephin did respond to Bartonella treatment. Well, there's also Ehrlichia, tick-borne illness, creates fevers and sweats and chills, headaches, myalgias, you feel tired. How would you know if you had it? Well, low white cell counts, low platelet counts, elevated liver functions during the summertime, treated with tetracycline and or rifampin if you're allergic. Babesia, probably the most important co-infection to look for. Tremendous increase in severity and symptoms. One of my patients was in a wheelchair for 6 years, having been treated for chronic Lyme. After her first course, after I found Babesia of Mepron and Zithromax, she walked for the first time. Now she's up and she's moving around, she's skiing, she's doing everything. Simply because that co-infection was making her so ill. The problem, of course, is it's difficult to find Babesia. The testing, very difficult. I've never found it on a standard smear. Unless the level of parasitemia in the blood is greater than 5%, you will not find it on a Guillain sustain. So that's why you need to do IFAs, fish testing, fluorescent in situ hybridization, where you look at the RNA of the organism under the microscope, PCR testing, maybe look for Babesia wall1, test for other species. Very, very difficult bug to get rid of, but tremendously beneficial in the Lyme community. And if you suffer from fevers, sweats, day sweats, chills, night sweats, and you are not getting better, you can almost be sure you have Babesia. Bartonella will also cause some sweats, but usually not as severe as you see with babesiosis. Treatment is Mepron and Zithromax. The old treatment, Cleocin and quinine, very difficult to tolerate. We will sometimes use Malarone, which is a combination of Mepron and Proguanil, because Mepron is very expensive, and these people relapse when they're taken off. When we tested for Babesia in our office, we found that 39, almost out of 100, would test positive by PCR and fish. but not by standard testing. And this is why these alternative tests for Babesia are so important. This is what the FISH test looks like under the microscope. You will see kind of that Maltese cross pattern of Babesia, which is fluorescent green. Usually has that, or it has the ring forms, which show up under the microscope. What about Bartonella? Dr. Fine has given wonderful presentations in the past on it. The most important thing probably to realize about Bartonella is many of you at this point have it. Again, it's atypical presentations. It's not the typical presentation of a papule and lymph nodes under your arm with fever. These are those people that might present first time with a new onset of a seizure, or have tremendous encephalopathy that's not getting better, or eye problems that are very, very severe, or very swollen lymph nodes. Those are your kind of clues to help diagnose Bartonella in these people. And we found if we rotate the regimens, if we give them, for example, a macrolide and Septra, Zithromax and Septra, or Doxy and Rifampin, or Doxy with a quinolone, and we rotate the regimens, many of these patients who do not get better would get better with Bartonella treatment. One of the great stories in my practice is a woman who came to me for 4 years who could not speak. She was getting better from Lyme treatment, but her speech never improved, and most docs would just give up. And of course, I'm always, well, let's try and help. Well, she finally tested positive for Bartonella after I came back from one of the conferences. We gave her doxycycline and Avelox, and the month later when she came in, she was speaking for the first time in 4 years. Now, if we had not seen this, I would not believe it. And she's still speaking and doing fine, and I can only imagine it was the Bartonella because I had not been using quinolones previously in my practice up till that point. 13% of our patients are testing positive for Mycoplasma fermentans. We tested approximately 750 patients in our practice. We did PCRs in the blood, 13% were positive. I'm not quite sure the role at this point, but I know that many of these organisms are intracellular, such as Bartonella and Ehrlichia and Lyme disease, and I know that in some of these patients, I have to use 2 drugs intracellularly to try and help them. And then maybe they'll get better. In the study we published a couple of years ago at the 16th conference, we had treated people for Mycoplasma fermentans for 1 year. It was approximately 6 months of macrolides, 4 or 5 months of tetracyclines, about 2 to 4 weeks of quinolones, and the mycoplasmas were still in the blood by PCR analysis. Very, very difficult to get rid of in these chronically infected Lyme patients. And that was the study that we presented. So the differential diagnosis, Lyme disease, symptoms come and go, migrates in your body. Women especially, you'll notice you flare right during your period or right before and after. If a woman tells me she's feeling much better but just flares around her period, that usually tells me I've probably knocked out the majority of the load in her body. But I still may need to pulse the antibiotics monthly, especially during that period. Babesia, malaria-like, fever, sweats, and chills, which complicate it. Much sicker patients, as published by Dr. Krauss. Ehrlichia, low white cell counts, low platelet counts, high liver functions. Bartonella, again, these people are much sicker. New onset seizures, bad lymph nodes, tremendously bad encephalopathy that does not get better, or eye problems. And then again, we're finding mycoplasma, chlamydia, herpes virus 6, HHV8, chronic fatigue syndrome viruses. So these are all the things we're finding in these patients who don't get well. We know that blood tests are unreliable. If you look at the very bottom, you'll see for Bartonella, it was even published in the Journal of Clinical Microbiology several times. There are serological limitations for Bartonella testing, as well as for Babesia, as well as for Lyme. These bugs are not easily found in the blood. So usually when we do the testing, we'll do ELISAs. Probably the C6 Lyme ELISA peptide would be preferable if you're going to do an ELISA at all. Of course, do IgM and IgG Western blots. Look at all of your co-infections for Ehrlichia and Babesia. Routine bloods, we'll certainly do CBCs, biochems, check everyone for thyroid disease. Certainly some of these people may have Wilson syndrome and have hypothyroidism. You may want to check their basal body temperatures. Check for vitamin studies. Many of my patients have high homocysteine levels, which of course is a marker for cardiovascular disease, for strokes and heart attacks, and also for memory. B vitamins and folic acid will help to lower it. Autoimmune panels, very important. Many of these patients will be immune dysfunction or have autoimmune markers. Check them for DHEA and cortisol ratios. Many of my patients have adrenal problems. When you're sick for so long, your adrenal gland will give out. Very useful to do hormone testing on these patients. DHEA to cortisol ratio is very useful. Some doctors will do growth hormone studies with L-arginine testing, also can be very useful. Immunology panels, some of the patients, the immunoglobulin levels are less. Dr. Katz is using IV immunoglobulins for some of these patients, and I just spoke to him. Some of his patients may be getting better with this treatment if their immune system is off. Functional medicine, I'm finding a lot of people test positive for heavy metals. Unfortunately, only 10 to 15% show marked improvement when I pull out the mercury and lead. But if you're in that 10 or 15%, you're very happy, because you might notice your fatigue and your joint pain and your memory gets better after I started to pull out the heavy metals. And this is a 6-hour urine DMSA challenge. It is not a hair analysis. It is not a blood analysis. The CDC published a study 2 years ago in 2003. It was a $6.5 million study. They tested 2,500 people for 116 different pollutants. They found all 116 pollutants in your bodies. They found 13 heavy metals, 14 combustion byproducts, and 10 pesticides in over 50% of the people they tested. So my take at this point is you need to look at detoxification protocols, because the cancer epidemic is mimicking the Lyme epidemic. And we know from Columbia University and many others that 95% of this is probably due to diet and the environment. Difficult diagnostic cases, we certainly want to do PCRs and check for different ways of looking for the co-infections. People also have reactive hypoglycemia, metabolic syndrome. If you get tired mid-morning or at 4 o'clock in the afternoon and you crash, this may be blood sugar swings. Do a 5-hour glucose tolerance test with insulin levels and take a look at it. Hormonal abnormalities, very, very common in these people. Need to be checked. I'd say that's really on the top of the list. Many people have low DHEA, testosterone levels, and they feel better when it's replaced. Autoimmune disease, very important. I certainly have referred to Dr. Fine often for these type of cases. Cognitive dysfunction. I'm very interested about these neurotoxins, because I've had patients now definitely improve with using IV glutathione, and I'm not sure what it's pulling out of the body. But it's an interesting drug because it's made in the phase 2 part of your liver for liver detoxification, where it takes fat-soluble chemicals, glutathione attaches, and it makes it water-soluble so you can eliminate it from your body. Glutathione is an antioxidant. It removes heavy metals. It helps to stimulate prostaglandin synthesis and protein synthesis, DNA synthesis in the body. It has multiple functions, so I'm not quite sure what it's doing, but it may be, because it works in some people in such a short period, that in fact maybe quinolinic acid or BB-tox1 or some toxin is responsible, and that would make sense. Why you're still sick after antibiotics. It could still be co-infections. It could still be autoimmune. It could be neurotoxins. And I think that's an area we need to look at in years to come. Immune support, very important. You all know after you get treated and you're feeling better, if you get a virus or you're in a car accident or something happens, you crash. So immune support as you're getting over the disease, physical therapy programs to stay strong, extremely important. And I can't underestimate the importance of psychological support. I'm embarrassed sometimes to give these statistics, but it is known that 1 to 3 or 1 to 4 women in the United States have been abused. And when I ask women in my practice, and I go deep and I ask them, have you had physical, emotional, or sexual abuse, many of these women admit to it. And I can tell you, until the abuse is taken care of, the Lyme will not get better. Because the mind and body work is one. This is how it works in the body. So I know that the healing that takes place is not just about antibiotics. It has to be a healing on all levels. And doctors, it's very important to ask about this. As I finish up here, what do we do in our office? I'm about to finish up. When we first see a patient with Lyme and tick-borne, we may want to start with a tetracycline like Doxy because it covers Lyme and Ehrlichia and maybe a little bit with Babesia. They used to actually use tetracycline, by the way, when you went to India to cover malaria organisms. And it hits Bartonella somewhat and Mycoplasma, so tetracyclines are good. But if you don't respond or worsen with it, then we may want to change the regimen. We might either want to add on a quinolone or a fampin if you have intracellulars, or we may want to change to a cell wall drug with a cystic drug with intracellular. Plaquenil is certainly very useful for people who have cystic forms or autoimmune overlap. We like to use nystatin, and of course we use a minimum of 45 billion acidophilus per day with probiotics to keep down the problems with the bowels. Certainly Saccharomyces boulardii is very useful with also bacteria, homeostatic soil organisms, other forms of acidophilus, very useful for keeping down C. diff. We have very few cases after treating 8,000 patients if you take enough acidophilus with Saccharomyces and some of these homeostatic soil organisms. If a patient has Herxheimer reactions, we found sometimes if we alkalize them, alkalizing the body can be very useful because we know that you create acid byproducts when you're very sick. We call this lemon-lime therapy, having patients take lemons or limes and squeeze them in water and drink it. I found it actually kind of funny myself when I tried it, but there are patients who do report that they get help. I'm not sure if it's the antioxidant capacity or it's really shifting the pH. Intramuscular bicillin. Dr. Fine was one of the first doctors who taught me about bicillin. So all of you here who have sore butts, you can blame it on her because I've used it since then, and it's a wonderful treatment. When I was a kid, my stepfather was a doctor, and whenever I got sick, my mother used to yell, "Harris, give him a shot!" So I kind of took this on as I got older, and now you're all getting these huge mega doses of stuff. So, but it's not on purpose. It's a great regimen. It really does a tremendous job. Monitor monthly blood work, CBCs and liver functions monthly. Continue antibiotics until 2 months symptom-free, or you're definitely going to relapse. Consider a trial off antibiotics. There are certain patients, when you treat them for candida with diflucan, small percentage. There was a German article that got published several months ago that diflucan is useful for neuro-Lyme. I tried it in my practice, it did not work, but what it did happen is that certain patients who had candida problems definitely improved, where their symptoms of fatigue or joint aches got better after diflucan, small percentage. And pulse therapies can certainly be useful. Once you've knocked down the major load of these organisms, you don't have to give antibiotics 7 days a week. That'll prevent the liver from having problems and the gut and the bowels from having problems. Pulse it 3 days a week. It still might be enough because they're slow-growing organisms once you've knocked down adequately the load. So we will combine cell wall, cystic form, intracellular drugs together to try and treat all the different forms, because if you just treat with amoxicillin alone, you may be missing some of the other forms as to how it hides in the body. So we kind of tend to combine these things together, where we might add on Mepron and Zithromax for babesia while we're still using amoxicillin in a patient. Or as I said, Plaquenil, Doxy with a quinolone, Cipro, or Levaquin. And even add on Lariam or Malarone to these patients if they test positive for babesia. Finally, Plaquenil, Zithromax, and Septra has been very, very useful, possibly sometimes with Mepron. So you're covering the Lyme, you're covering Bartonella, and you're covering babesia. I imagine this as several armies attacking your body at once. These are all the organisms that are the armies. If you were a commander and you had several armies attacking you, would you just want to go after one of the armies? Or would you have your defenses and your armies go after each one of those? So that's kind of how I think about it in those terms, is I want to use all of these different bugs. By the way, if you want to know who did this, this is my PA Dylan, who gets all this stuff to fly around on the computer. He's created all these marvelous slides. I don't know what all this means, but I just love watching these things fly around when I'm doing it. Actually, if you look at it, what it is we linked up the drugs with the bugs here. So it's kind of nice. So the whole point of this is, I showed you this first slide, this universe. This is kind of how we think about it. Look at all of these bugs and co-infections, all the drugs used in combination. Think neurotoxins, possibly heat therapy in some of these patients. Old studies years ago showed that Rocephin was 4 to 16 times more effective at higher body temperature. It's not being adequately used. Think about immune regulation, candida problems, food allergies, heavy metals, multiple chemical sensitivities, hormonal problems. We have a 17 numbered list in our office. If you don't get better, we make sure we go down that list to make sure that nothing has been excluded. The most important thing that a doctor must have, which unfortunately I'm not sure if they were taught in medical school, is that wisdom is the marriage of knowledge and experience bound by compassion. When I was finishing medical school and I went to my teachers and I said, what is the most important thing you want to teach me? When I go out in the world, they said, compassion. Put yourself in the person's shoes and treat them as you would want to be treated. Thank you so much.
All right, we'll do a little question and answer session.
Yes.
Yes. I understand there's a specific clay, and it comes from Israel, and it is a metal, toxic metal detoxifier. Are you familiar with that?
No, I know that some people have used bentonite in protocols specifically.
That's what it is.
Yeah, bentonite clay has been used in different protocols to detox people. But I don't have a lot of experience personally using it. Yes.
Dr. Horowitz, I was just wondering about your opinion in regards to whether or not there are in fact more co-infections in the ticks, especially in the, sort of the East Coast corridor, and specifically in reference to the presence of prions. And the reason I ask this question is there was a recent documentary on Discovery about a prion they had found in an African colony that caused a disease called Kuru, which I'm not familiar with. But in any case, it is a movement disorder, much like kind of dysphoria and kind of like Parkinson's. And it's also a slow-growing virus. And so I was wondering, I wonder if that also is in the cesspool of ticks here on
The question is whether there are other co-infections and possibly prions, which is the one that causes mad cow disease possibly at this point, because there's Kuru. It's a disease actually they find it, I believe it's in sheep actually, is when they first discovered it. And it's kind of a Jacob Creutzfeldt type, slow virus type disease where people get dementia. As far as I know, we haven't seen in the Lyme patients at this point prion disease, only from the point of view that we haven't seen any of the patients who present exactly that way. I think the problem is more what you saw this morning, is the large number of patients who present with demyelinating diseases, such as MS and ALS. I mean, I have many ALS patients at this point in my practice, and of course they've all tested positive for Lyme. The problem from my perspective is I'm not quite sure if it's prions, but I suspect, just because I've been digging in the environmental medicine workplace for so long, the government has shown there's 300 to 500 chemicals in your body right now. Many of these are carcinogenic and may cause demyelinating disease. So is it possible that some of these are causing some of these overlapping problems in people? Maybe. But prions, I don't think we've ever found this.
The Connecticut Department of Health has done extraordinary testing on ticks. If you go to their website, you can see all the tests, and if you have further questions, you should call them because they're continuing to test.
Yes, Beckman. Yes, agree.
I like your song very much, thank you. It's nice to hear discussion, it's nice to be here. I wish I would have been saved by you. We're at the tip of Cape Cod, Massachusetts, like things to get treated. And we have, can we get a transcript of what you said here, so I can't write that fast?
Are you trying to say that I speak quickly?
It's
If you think this is quick, you're going to see what goes on in my brain while I'm talking. They're making tapes. Oh, they are making tapes, actually. Yes.
I think you could save somebody if you know anybody in Massachusetts, not working.
Yeah. Usually, if you speak to the LDF or the LDA, usually they have lists of physicians in the area. I think even ILADS may have groups of physicians that may be in the area, so that's probably good places to start.
For tapes, I guess they'll contact you, or who should they contact? Huh? Okay, you can call Randy, who will direct you to the person who's making the videotapes and DVDs also, or whatever. Okay. Thank you very much. Now you know why we get into trouble for doing excessive testing, because we have to.